Hello, my name is Dr. Christoph Corell. On behalf of CME Outfitters, I would like to welcome you and thank you for joining us for episode 2 of a 3-part CME OCAST series on reducing symptoms and restoring function in patients with schizophrenia. What's the latest evidence? Today's episode is titled Current and Emerging Therapies for Schizophrenia, How Mechanism of Action Affects Outcome. This activity is brought to you by CME Outfitters, an award-winning accredited provider of continuing education for clinicians around the globe. I am a professor of psychiatry and molecular medicine at the Zucker School of Medicine at Hofstra Northwell in Hempstead, New York, and the medical director of the Recognition and Prevention Program at Zucker Hillside Hospital, Department of Psychiatry in Glen Oaks, New York. Our learning objective today is to differentiate the mechanisms of action of current and emerging therapies for their influence on clinical outcomes in individuals with schizophrenia. Let's talk about different treatment targets in schizophrenia, mapping these targets onto the brain and onto the known neurotransmitters. Let's start with the well-known dopamine system, which seems for currently available treatments the sine qua non, the necessary ingredient of antipsychotic treatment, at least for positive symptoms. Why? Because D2 antagonism has been shown to reduce positive symptoms, delusions, hallucinations, disorganized thinking, and disorganized behavior. Now, D1 agonism could actually improve cognition, and we don't want too much D1 antagonism. D3 antagonism can also potentially worsen cognition, but partial agonism that stimulates some part of the D3 receptors might improve both negative symptoms, cognition, as well as mood and motivation. What about serotonin? We know serotonin very well from antidepressants, where we have reuptake inhibition. But partial agonism on 5-HT1A agonist receptors can actually improve anxiety, reduce akathisia. Also, blockade of certain serotonin receptors, 5-HT2A, 5-HT6, and 7, can help with depression and may also reduce EPS. And there's also a possibility for improvement of negative symptoms as well as depression. Norepinephrine is also known to us from antidepressants. There's an unclear impact on positive symptoms, whereby some studies of older tricyclic antidepressants have shown potential worsening of psychosis, but newer studies show no worsening of psychotic symptoms, but potential to relieve negative symptoms and clearly relieving depression. The Gaba system is known to us from benzodiazepines, and here this can be used as augmentation to reduce symptoms of psychosis, agitation, anxiety, and insomnia. The cholinergic system is very relevant for cognition. We have here nicotinic and muscarinic receptors, and agonists on that system can help cognitive symptoms. But some of our antipsychotics have cholinergic blockade built into their mechanism, which can then potentially worsen cognition, but it might also relieve some positive symptoms. Finally, the glutamate system is very important because too little glutamate drive might actually be related to negative symptoms and cognitive impairment. Too much glutamate can be neurotoxic and may also be related to psychotic symptoms. We all rely very much on the dopamine hypothesis of schizophrenia, which is somewhat reverse reasoning because the only currently known antipsychotics have in common dopamine blockade. We believe that in certain areas of the brain, the Mesolimbic Pathway, or certain areas of the striatum, where there's too much dopamine, you can get, based on the genetics, psychosis, agitation, mania, or aggression. Blocking dopamine in these areas can be antipsychotic, anti-aggressive, anti-manic. However, that dopamine system doesn't explain the co-occurrence of positive as well as negative symptoms. So it seems that in another area of the brain, there's actually hypodopaminergia, and that is particularly true in the subcortical and prefrontal areas. That hypodopaminergia might actually, via feedback mechanism, secondarily lead to the hyperdopaminergia in the areas related to activity, behavior, and also psychosis. Current antipsychotic drugs block dopamine postsynaptically, thereby somewhat even stimulating the already increased production of dopamine until a new equilibrium has taken place through enough postsynaptic dopamine blockade. However, PET data seem to suggest that the actual psychopathology of schizophrenia is not related to postsynaptic problems, but to the presynaptic overproduction of dopamine. And we will hear in the emerging drug section of this program how novel approaches might actually target exactly that system. Let's talk a little bit more about the dopamine family. There are 5 dopamine receptors, and they're in 2 different families. The D1 and D5 receptor travel together in terms of their activity. They're responsible for working memory and attention, as well as pain and affective functions. D2, D3, and D4 receptors are also involved in memory and reward, as well as cognition and emotion. Let's have a look now at the different dopamine receptors, serotonin receptors, localization, and what happens in the brain when these receptors are stimulated. We have D1 and D2-like receptors throughout the brain, and their localization is different. We have different pathways for dopamine receptors, including the mesocortical, nigrostriatal. Nigrostriatal is separated into the sensory motor striatum and the associative striatum, with the Mesolimbic pathway and the tubero-infundibular hypothalamic pathway. Let's take a look first at the mesocortical pathway. This is important for our cortical functioning. If there's too little dopamine, we may have negative symptoms, cognitive impairment, depression, and even akathisia. The nigrostriatal pathway separates into the sensory motor striatum on the one hand, which has to do with movement. When there is too much dopamine blockade and too little dopamine transmission, patients can have dystonia, akinesia, rigidity, tremor, or develop dyskinesia. The second nigrostriatal pathway has to do with the associative striatum, and we believe if there's too much dopamine in this pathway, then psychosis, mania, and even aggression can be a result. We have the mesolimbic pathway, which is part of the limbic striatum, and here again, too much dopamine might lead to positive symptoms. Finally, we have the tubero-infundibular hypothalamic pathway, which has to do with prolactin production. Dopamine is actually PIF, prolactin inhibiting factor. When that factor is inhibited, prolactin is being disinhibited and increases. That prolactin increase can interfere with sex hormone production, leading as a net effect to a reduction in estrogen as well as testosterone. That reduction in sex hormones can express itself through amenorrhea, galactorrhea, or sexual dysfunction, including erectile dysfunction, anorgasmia, or decrease in libido. Where do these dopamine receptors sit makes a difference too, because the localization of these receptors is different. But our antipsychotics that we all prescribe as dopamine blockers have a different affinity that is either more or less geared toward D1, D2, or D3. You can see on this slide that the agents that have the strongest D1 blockade relative to D2, and we need 60 to 80% of D2 blockades to have antipsychotic efficacy, are asenapine, olanzapine, and clozapine. So with these agents, you get not only D2, but also D1 antagonism. The agents that are the least D1 blocking, which can potentially worsen cognition, are aripiprazole, lurazidone, brexpiprazole, and cariprazine. Although all antipsychotics block dopamine D2 receptors, what is the relative binding affinity for D3 receptors? We know that the tightest D3 binding agent is cariprazine. There are many agents that have somewhat lower D3 than D2 antagonism. Cariprazine is a partial agonist there. And we have some agents that have very little D3 activity, and these are called brexpiprazole, iloperidone, and lurazidone. So in effect, simplifying this D2 to D1 or D3 ratio, we have three different families of antipsychotics. The D3 preferring agents, which are cariprazine and lonanzarine, which is not available in the United States. D1 preferring, which are asenapine, olanzapine, and clozapine. And the typical D2 preferring agents, which are brexpiprazole, paliperidone, aripiprazole, risperidone, ziprasidone, iloperidone, lurazidone, and quetiapine. Sometimes clinicians have felt that partial agonists on the D2 or D3 receptor may not be as effective as full antagonists. There have been two studies of long-acting injectables where a partial agonist was compared to a full antagonist. One was the QUALIFY study, where aripiprazole maintena was compared to paliperidone palmitate, where in terms of maintaining efficacy, there was similar outcome, but there were advantages for quality of life for the partial D2 agonist aripiprazole maintena given as a long-acting injectable. At that time, in this study, there was no measurement of symptoms, and that had been a criticism of the study. So in another study, the Alpine study that was presented in 2019, another aripiprazole long-acting injectable was compared with paliperidone palmitate, and this was aripiprazole loroxal that was given as 1,064 milligrams after an initiation schedule that is new. Before, aripiprazole loroxal had to be co-prescribed for 3 weeks with oral aripiprazole, as aripiprazole maintena has to be initially co-prescribed with 2 weeks of oral aripiprazole. Now, aripiprazole loroxal has a new formulation, which is called Initio, which is a once injection followed by one single dose of 30 milligrams of aripiprazole, and then no other oral treatment is needed. And the monthly injection with loroxal can continue. Paliperidone was dosed as usual, 230 milligrams on day 1, a booster injection at week 1 with 156, and then every month thereafter, the dosing that was appropriate to the patient. In this study, the results were that basically the improvement in symptoms was similar for both aripiprazole loroxal as well as paliperidone palmitate. So the partial D2 agonist and the full D2 antagonist did equally well during week 4, 9, and 25. Dopamine transmission can have different phases. The first one is the usual physiologic one, where an agonist, in this case dopamine, hits the receptor, and postsynaptically dopamine transmission takes place, and then the dopamine is reabsorbed into the presynaptic synapse. The first antipsychotics ever discovered were full dopamine antagonists. These medications sit at the dopamine receptor and they block these receptors so that the endogenous dopamine cannot get to the receptor and initiate the postsynaptic transmission. A dopamine partial agonist is something in the middle, in that these medications sit at the dopamine receptor. Endogenous full agonist dopamine cannot reach that receptor and exert postsynaptic transmission, but these partial dopamine agonists have so-called intrinsic activity, thereby stimulating the dopamine transmission to a degree, but not overstimulating it. Finally, we have another receptor modulating type, and these are so-called inverse agonists. Here, the medication sits at the receptor. Endogenous dopamine can't get to this receptor, doesn't induce transmission. But instead of being a silent antagonist, these medications set the receptor transmission in reverse and exert the opposite function as if a full agonist would hit that receptor. We've talked about dopamine a lot, but we've also talked about other receptor types. And the brain is a wonderful place. It is very connected, and these different receptor types are interconnected via interneurons, so that there is fine-tuning in the brain that takes place with each of these transmissions. We know, for example, that serotonin and dopamine interact with each other, because when agents have 5-HT2A antagonism, that then releases a little bit more dopamine transmission so that there's less extrapyramidal side effect possibility. Also, partial agonism on the 5-HT1A receptor might reduce akathisia. And obviously, increasing serotonin transmission via other mechanisms like reuptake inhibition can help with anxiety, depression, and potentially negative symptoms. But also, the different receptors on the dopamine family might, via partial agonism, via D2 and D3 partial agonism, further reduce negative symptoms. Clearly, what we need are medications with novel mechanisms that interfere with GABA, glutamate, oxytocin, opioid receptors, cannabidiol receptors, acetylcholine receptors, so that we can fine-tune the different receptor types and create better transmission in the brain to not only address positive symptoms, but also negative symptoms and cognition in people with schizophrenia. What makes an antipsychotic atypical? Meaning, what doesn't cause too much dopamine blockade, leading to extrapyramidal side effects like Parkinsonism within the dose range where these medications are effective against psychotic symptoms. You can either have a low D2 occupancy over the full dose range, that is a looser binding antipsychotic like quetiapine or clozapine. There can be partial D2 agonism, also with brexpiprazole, aripiprazole, and cariprazine. And with cariprazine, you can see partial D3 agonism in addition. There can be modulation of dopamine activity via M1 muscarinic and H1 histaminic blockade, which actually counter the EPS, but also can lead to cognitive side effects as well as sedation and weight gain. There's this indirect augmentation of dopamine activity leading to not full shutdown of dopamine transmission via stronger 5-HT2A binding than D2 binding, or also 5-HT serotonin 1A partial agonism. The fast dissociation from the receptor is basically the same as low occupancy, so quetiapine and clozapine would have that. There are three partial D2 agonists, easy to remember: A, B, C, aripiprazole, brexpiprazole, and cariprazine. They're not exactly the same. The partial agonism of aripiprazole and cariprazine might be somewhat higher than of brexpiprazole. Also, there is tighter D2 binding than D3 for aripiprazole, and very little D3 binding for brexpiprazole versus cariprazine that has a 10-fold higher affinity for the D3 receptor and the D2 receptor, being a partial agonist on both. There are also differences in the 5-HT2A binding, which is the highest with brexpiprazole, leading to very little EPS compared to cariprazine, which has actually the least 5-HT2A binding. Also, brexpiprazole has the tightest 5-HT1A partial agonism binding relative to D2, which leads to even less akathisia than with aripiprazole and brexpiprazole. What does partial agonism at the D2 receptor do? The dopamine receptor is stimulated fully when dopamine engages with that receptor. When we have a full antagonist like haloperidol, that receptor is silenced. It is blocked, and the endogenous dopamine cannot stimulate it. That means in some areas there might be too little dopamine that is necessary for physiologic action of cognition, of drive and wanting, seeking reward, being socially active. A partial agonist sits at the receptor and has so-called intrinsic activity. So it does stimulate the dopamine receptor, but not as much like a full agonist like dopamine. Thereby, it somehow levels the dopamine tone. In areas of the brain where there's too much dopamine, it brings it down to the 20 or 30% intrinsic activity. And in areas where there's too little dopamine, it brings it up to 20 or 30%. This is very relevant because it can stabilize dopamine, but it also depends on the dose, because you need a higher dose in order to block enough receptors that otherwise would not only receive intrinsic activity, but also the activity of endogenous dopamine. So when a patient doesn't have sufficient D2 blockade or dopamine transmission reduction, the dose of the partial agonist should be adjusted upwards. Let's summarize with our SMART goals: specific, measurable, attainable, relevant, and timely. That is what we hope that you will take from this discussion to apply to your practice. We hope to have succeeded that you are now able to distinguish the dopaminergic binding affinities of various antipsychotics and their impact on safety and efficacy better. And also that you'll be able to identify how antipsychotics target different dopamine receptors to exert their clinical effect.